هو الموضوع اللي هتكلم فيه النهارده هو النيوروسايكايتري اوف تروماتيك برين انجري. وده حقيقه تخصص انا اشتغلته في انجلترا من كذا سنه يعني، برين انجري يونت، وهو يمكن تخصص not very common في المنطقه هنا كسب سبيشاليتي البرين انجري او سبيشاليزد برين انجري يونتس. انا هتكلم يعني overview of the main aspects of the neuropsychiatry of the TBI or what we call TBI. I'm going to start off الأول with some learning objectives and aims, epidemiology and global burden, and types and causes of TBI, mechanisms and pathology associated with TBI, how to measure the TBI severity. The main focus هو neuropsychiatric sequelae and their management, whether it's cognitive, emotional, behavior, or psychiatric. We'll start off with a definition. What do we mean by a traumatic brain injury? So it's any alteration in brain function or any brain pathology caused by an external force. I want to stress the point of external force, and this is what differentiates traumatic brain injury from other causes of acquired brain injury, like hypoxic or vascular or degenerative brain injury. The external forces is the main differentiator. The alteration of brain function is manifested either by altered conscious level, altered mental state, memory loss for events before or after the injury, and frank neurological deficits, or a combination. I'll go straight into the epidemiology. The TBIs affect about 2 out of every 1,000 people per year. It's low incidence, and the majority of cases, 80% of them, are classed as mild. And this is what we commonly call the post-concussion syndrome. This refers to a group of physical, cognitive, and emotional symptoms that can persist for weeks, months, or even years following a mild TBI. Classically, early on, it's associated with a physical, cognitive symptoms. So physical symptoms like headache, nausea, dizziness, slurred speech, unsteadiness in the gait. And cognitive symptoms like poor concentration, slowness in response to questions. Later on, the emotional symptoms, such as irritability and anxiety, predominate over the physical and the cognitive features. Most cases are self-limiting, and permanent problems are usually uncommon. But that's in terms of incidence. Prevalence, in general, prevalence is quite high. So about 12%. And this is according to a meta-analysis from 2013 that looked at 25,000 adults across 15 studies, but 12% prevalence. So low incidence, about 0.2%, high prevalence. And this really stresses the point that when TBIs happen, the injuries are usually for life. Demographics data, it's predominantly a male disorder. So males are affected twice as much as females, and they die about 4 times as much as in females. It's more common in the younger age, so late adolescence, early adulthood, 15 to 25. It's the leading cause of death and disability under the age of 45. Mortality is about 25 per 100,000. The risk of TBI increases in lower socioeconomic status, and alcohol is involved in more than half of all cases. Globally, about 10 million people are either hospitalized or die as a result of TBI, and it's estimated that worldwide about nearly 60 million people have been hospitalized at least once with TBI. Now, what are the leading causes of TBI? Globally, it's motor vehicle accidents, more than 50%. The leading military cause is blast injuries. In our part of the world, in the Middle East and North Africa, again, it's motor vehicle accidents, followed by military causes like blast injuries. And this is from a study done in Lebanon, a systematic review. Overwhelming majority, 85% affected, were males. About 2/3 of the cases were mild, 63%, 10% were moderate, and about 20% had severe. And again, that's not surprising when you consider that driving in the Middle East is quite a risky business. In terms of cost, direct medical costs in the US, it's about $60 billion a year. And when we take into that the quality of life and lost activity, direct, what we call direct and indirect costs, it's about 200 billion. And I want to go back to this idea of external forces that we mentioned in the definition. And we said this is what differentiates traumatic from other acquired brain injuries. There are different types of external forces. So we have what we call the biomechanical force. So this is the head striking or being struck by an object. We have what we call rapid acceleration or deceleration. So this is associated with motion. And then we have penetration by a foreign object or blast-related forces. And this leads to two types of head injuries, what we call the open head injury, where the skull and dura are perforated. There's penetration and injury to tissue with tissue damage from the transiting object to the brain tissue. And the second type is what we call the closed injury, where the skull and dura are intact. And this is usually associated with the first two types, the biomechanical and the acceleration, deceleration type. So biomechanical injuries, so a simple example would be walking into a door or into a window, for example. So this involves the head or the brain being struck to a fixed object. So at the site of the injury is what we call the coup injury. And then the opposite side of that, because of the rebound of the brain, is what we call the contra-coup injury. In terms of acceleration and deceleration, normally the brain is floating inside the CSF within the skull. But if, for example, a car is moving and then suddenly it stops because of the momentum, the brain can impact on the front of the skull, or if there's sudden acceleration from a stationary position, aspect of the brain can impact the skull. So normally when there is no impact, like you said, the soft tissue is not in contact with the hard skull. But when there is impact, the soft brain tissue hits the hard skull, and this results in two types of injury: white matter injury and gray matter injury. So the white matter injury involves what we call a shearing effect. So this is stretching or tearing of the axons, and this results in diffuse axonal injury. You can see a blood vessel there. So the blood vessel is intact, it's not injured. And the second type, the gray matter injury, is as a result of contusions due to injury of the blood vessels. So the primary pathological changes we see in TBI result from, like we said, white matter diffuse axonal injuries and the gray matter contusions. Okay. And CTs and MRI scans are not particularly good at picking up the white matter injuries, unless they are accompanied by contusions and injury to the surrounding blood vessels. And this explains why, with many of the head traumas, particularly the mild head traumas, you might get symptoms, but the scans appear as normal. Then there are secondary effects like cerebral edema, raised intracranial tension, and cerebral ischemia and herniation in extreme situations. The major sites of vulnerability for TBI can happen anywhere, but the major sites are the orbital surface of the frontal lobe, especially the medial aspect, and the tips on the underside of the temporal lobes. So, how do we measure the severity of TBI? We can use several different methods. So we're going to talk about three different methods here. First is the level of consciousness, so alteration of the level of consciousness. The second is the duration of the loss of consciousness, or LOC. And the third is what we call the duration of PTA, or post-traumatic amnesia. So level of consciousness, as I'm sure you're all aware, can be assessed using the Glasgow Coma Scale, which is given a score out of 15 for eye-opening, verbalization, and motor activity. And in general, the GCS is a poor predictor of outcome in TBI. So you can have very low GCS and still have a good outcome. So it doesn't really tell us very much. Better predictor is the duration of loss of consciousness. So this is how long people lose consciousness for. And it's a better marker than the GCS, and particularly good for moderate and severe brain injuries, but a poor predictor of outcome when it comes to mild TBI. The best predictor we have is what we call the duration of PTA. So post-traumatic amnesia can be defined as the interval between the onset of the injury and the return of continuous day-to-day memories. There's a very robust method of measuring it called the GOAT, or the Galveston Orientation Amnesia Test. So this is a tool where a score is given out of 100 for different aspects of orientation and memory. You deduct scores, and it's administered daily, so that you can monitor the progress of the patient. And anyone scoring above 76 is considered within normal. And you measure the number of days it takes to get back to normality from PTA. PTA is a good predictor, even in mild cases of traumatic brain injury. And in general, if the PTA is less than a week, we expect a good outcome. More than a month, we expect significant disability. So just to summarize, so this is how we class the mild, moderate, and severe according to the three methods. So GCS 13 to 15 is mild, 9 to 12 is moderate, 6 to 8 severe, 3 to 5 is severe. Loss of consciousness less than 30 minutes is mild, 30 minutes to 6 hours moderate, 6 hours to 7 days severe. Less than 24 hours is mild, 24 hours to 2 weeks is moderate, 2 to 8 weeks is severe, and more than 8 weeks is very severe. Next, I'm going to talk about the neuropsychiatric sequelae, and this is the main focus of our talk. So as we said earlier, a head injury is for life, because we said it has high prevalence, low incidence. So in the US, about 5 million people, or approximately 2% of the population, are living with disabilities as a result of TBI. And it's the neuropsychiatric sequelae rather than the physical sequelae that are the major cause of disability after TBI. So the main domains that we look at when we come to assess neuropsychiatric sequelae are the cognitive domains, emotional complications, behavioral changes, and psychiatric disorders. So cognitive impairment can be both short and long-term. We've already talked about the short-term in terms of impaired consciousness and post-traumatic amnesia. And these resolve, the overwhelming majority of patients fully resolve within 6 months. Long-term cognitive impairments affect about 2/3 of patients who have moderate or severe TBI. About a quarter of them will not return to work. And outcome is influenced by a number of parameters, including loss of consciousness, the type of pathology, and the person's premorbid characteristics. So if there's a cognitive reserve, then that obviously can be predicted. The highest rates of recovery are seen in the first year. And then after the first year, the results tend to plateau, but we have seen improvements sometimes up to 5 years post-head injury. So the main cognitive domains that are affected include memory, attention, and concentration. Second is processing speed, and the third is executive functioning. There are a number of different neuropsychological tests we can use to assess these different domains. So how do we treat? The main treatment, we have pharmacological agents, but there are also non-pharmacological methods, such as cognitive rehabilitation therapy, or CRT. And the basic principle behind it is that either aim at restoring what cognitive functions have been lost, or if they've been completely lost, we try to teach the patients compensatory skills to compensate for whatever has been lost. In terms of medication, any prescribing that we do is strictly off-label. There are no FDA-approved medications for cognitive sequelae of TBI. And depending on the domain, we can recommend different medications. So for executive dysfunctions, dopamine agonists are reported to produce results. For memory deficits, we can use cholinesterase inhibitors, as we do, for example, with dementia patients. And for the processing speed difficulties, we use stimulant medications, so like atomoxetine or Ritalin, for example, that's used in ADHD. So these are some recommendations. So for memory deficits, you can give donepezil, or processing speed difficulties with methylphenidate. Executive dysfunction, a dopamine agonist like amantadine. The emotional deficits are seen in the early part of the TBI as part of the delirium or the post-traumatic amnesia. But there are also longer-term emotional deficits that include a number of different domains, including pathological laughing and crying, affective lability, and irritability. So I'll start with the pathological laughter or crying. So this is where there's intense, uncontrollable episodes of laughter and or crying that is incongruent to the situation. So it's we sometimes call this the pseudobulbar affect, sometimes called emotional incontinence. That's frequent, seen maybe up to 10%. Recently portrayed very well in the Joker movie, where he had traumatic brain injury and he had uncontrollable laughter. PLAC responds well to both serotonergic and noradrenergic antidepressants, but again, prescribing is off-license. SSRIs are a good first-line treatment, so something like sertraline or citalopram, for example. Affective lability is another type of emotional disorder where there are congruent emotional expressions, but they tend to be exaggerated. So very intense emotions, but in general appropriate to the situation. So it's the congruency aspect that differentiates it from the pseudobulbar affect. And this is more common, or can affect up to 60% of patients in late TBI and nearly half of all patients in early TBI. And it follows the same recommendations of treatment as the pseudobulbar affect. Irritability is a very common problem, so it affects about patients. We also call this sometimes intermittent explosive disorder or episodic dyscontrol. So this is where there are recurrent outbursts of anger, also either very minimal stimuli or non-existent stimuli that are very out of character to the person's pre-morbid traits. Very explosive. The caregivers describe it as walking on eggshells or walking on a minefield. And patients, when they're out of this explosive anger, they tend to express remorse later on. Treatment, anger management, so non-pharmacological treatments are the first line. Pharmacological agents, we have case reports for mood stabilizers and a single RCP for something like Apathy. In practice, we use things like sodium valproate, and there tends to be a good response to that. In terms of the behavioral deficits, these include three. So the first is disinhibition. So these are socially inappropriate, non-aggressive, verbal or physical or sexual acts. And it's as a result of the patient not appreciating the social norms, so they're unable to pick up on social cues. It's frequently associated with impulsivity and inability to delay gratification, verbally, physically, or even sexually inappropriate. In moderate to severe TBI can affect a third of patients, and it generally has poor long-term outcomes. Behavioral interventions are effective, but pharmacological interventions, the evidence base is poor, and we tend to borrow medications that have been used in other disorders where there have been disinhibition, for example, like dementia. So SSRIs, anticonvulsants that may have anti-impulsivity actions. So aggression, to differentiate it from earlier irritability we talked about, are actual outbursts of physical violence. So they may be preceded by irritability. Okay, so it has many of the similar features. It can affect half of all patients in late TBI, and there's an association with premorbid antisocial personality disorder. And it tends to have particular characteristics, so it tends to be reactive. So, like we said earlier, it's triggered by modest or trivial stimuli. So something that may not necessarily make people angry makes them very angry and very aggressive. It usually doesn't involve any planning. It doesn't serve any purpose or goals. It tends to be explosive. It tends to be periodic in that there are long periods of relative calm in between the outbursts of aggression. And it's also ego-dystonic in that patients show remorse for their behavior later on. Behavioral interventions using the ABC approach or modified CBT can be useful. The only pharmacological approach we have for post-traumatic aggression is actually for beta blockers like propranolol or pindolol. limited evidence for the use of antipsychotics and mood stabilizers, although we frequently use it in practice. Apathy, on the other hand, is a reduction or an absence of goal-directed behavior, cognitions, and emotions. There's a lack of effort and initiative, decreased interest, lack of planning and concern, and flattened emotional responses. And the frequency ranges from 20% up to 72%. There's a high overlap of these symptoms with the symptoms of depression, and they can frequently be difficult to differentiate. But we do have validated rating scales that can help differentiate these symptoms from the symptoms of depression. Again, the evidence base for apathy is not great in terms of treatment. Majority of studies, usually small studies, case reports or small samples, use stimulants or dopamine agonists, so methylphenidate or bromocriptine or amantadine, show positive results. Not much evidence for the behavioral interventions. And finally, we'll talk about the psychiatric disorders that we can see post-TBI. By far the commonest is post-traumatic depression. And rates are very high, but can be as high as almost 3/4 of all patients. We diagnose depression in TBI using the standard diagnostic criteria. And the emergence of depression is related to a number of variables, so things like premorbid characteristics, so if there's a genetic vulnerability or a past psychiatric history. Factors related to the TBI itself, so the type, the extent, and the location of the injury. And also factors that influence recovery, so the presence or absence of social support, the degree of the functional recovery, can all impact on the emergence of depression. Treatment, psychotherapy is an option, so educating the patient regarding the TBI, managing their expectations, offering them support and giving them reassurance. CBT can help problem solving and improve self-esteem. The pharmacotherapy, SSRIs are recommended as first-line treatments, and the best evidence we have are for both sertraline and fluoxetine. But choice in general is guided by how well the medication is tolerated, side effects, interactions with other medications that may be being prescribed at the same time. In resistant cases, ECT has been used. Mania is quite rare, so the highest rates reported are around 9%. Symptoms are similar to non-TBI mania, so we can get mania, hypomania, or mixed states. But just bear in mind that some of the features of mania can overlap with other symptoms of TBI, like the irritability, the impulsive disinhibited behavior, the pathological laughter and crying. Again, treatment, evidence base is not great. So again, we rely on case reports and uncontrolled studies. So valproate and quetiapine are recommended as first-line treatments. Other mood stabilizers like lithium, for example, may worsen cognitive impairment, so we need to be cautious when we prescribe these. Psychosis is another rare but severe consequence of TBI. And again, highest rates reported around 10%. And the onset of psychosis can take some time, on average up to 5 years. This is on average. The longest reported onset of psychosis post-TBI has been, in some cases, 20 to 25 years. So it doesn't have to appear immediately following the head injury. There's no specific anatomical correlation associated with psychosis. The main categories that we see are delusional disorder, so this is where patients present only with delusions in the form of Capgras syndrome and reduplicative amnesia. Or they can present with schizophrenia-like psychosis, where there are delusions and hallucinations. The commonest being auditory hallucinations and persecutory delusions. Negative symptoms are much less prominent. Again, the literature doesn't support the superiority of any one particular antipsychotic. Olanzapine can be a reasonable first-line choice, but just remember when you're prescribing that start low with 1/3 to 1/2 of the start dose. And finally, anxiety disorders can occur, quite common, up to 70% of patients, the commonest two types being GAD and PTSD, but other types can occur as well. Treatment, again, limited evidence-based, but case reports recommend SSRIs, venlafaxine, buspirone. Be cautious with benzos and antipsychotics because they can cause memory impairment and delay neuronal recovery. And finally, CBT is always a good option.